A very good evening and warm welcome everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes the speakers and the viewers who have joined in for today's discussion on uniting voices and taking actions for multiple myeloma, organized by Voice of Healthcare and powered by Manipal Hospitals to recognize Multiple Myeloma Awareness Month. This panel aims to raise awareness about multiple myeloma and highlight the challenges faced by patients. We will discuss the latest research and treatment option as well as the importance of early detection and ongoing care. To commence this session, I would like to introduce our eminent speakers today. I welcome Dr. Mallikarjun Kalashetty, consultant hematology, hemato-oncology, and bone marrow transplantation, Manipal Hospital, Old Airport Road. Welcome, Dr. Kalashetty.
Hello, Dr. Ritika. Thank you for having me. Good evening to all your viewers.
Dr. Satish Kumar A, consultant hematologist and hemato-oncologist, Manipal Hospital, Yeshwanthpur and Hebbal. Welcome, Dr. Kumar.
Hi, Dr. Ritika. Good evening to everyone. Thank you for having me for the show.
Dr. Ashish Dixit, consultant hematology, hemato-oncology, and bone marrow transplantation, Manipal Hospital, Old Airport Road. He will join us in a bit. So, starting with this discussion, I would like to ask Dr. Mallikarjun, so what is multiple myeloma and what are the methods used to diagnose it?
Yeah, thank you for the question. So, good evening, everyone, again. So, this is important debate that we are having today. The whole idea, as Dr. Ritika mentioned, is to create awareness regarding multiple myeloma. So, multiple myeloma is one of the commonest blood cancers, accounting for about 10 to 15% of all blood cancers. It is a cancer which arises from plasma cells, which are the cells in the bone marrow. Typically, bone marrow plasma cells account for less than 5% of all nucleated cells. When the plasma cells proliferate more than 10%, with various other things that we'll discuss, it causes a condition called as multiple myeloma. Now, how do we get to a diagnosis of multiple myeloma? There are certain common clinical manifestations that patients present with, and then there are some laboratory tests which help us in confirming this diagnosis. Now, like many other cancers, multiple myeloma indeed is a cancer which affects the elderly age group more commonly. The median age of presentation of multiple myeloma in Western world is about 63 to 65 years, whereas in our own country, it could be little sooner than that, perhaps between 55 to 65 years. Now, most patients of multiple myeloma present with certain common clinical manifestations like weakness, fatigue, bone pain, back pain, which is chronic, progressive, and perhaps worse in the night time. And left untreated, they will have other issues like hypercalcemia, renal failure, and lowering of the hemoglobin. When patients present to us with such manifestations, there are certain basic investigations that we do initially, which consist of blood counts, liver function, kidney function test. We also investigate for an abnormal protein called as monoclonal paraprotein. Now, the evaluation for this abnormal protein, which is also called as myeloma associated protein or monoclonal paraprotein, is fairly simple. We do a blood test called as serum protein electrophoresis, serum kappa lambda light chain ratio, serum immunofixation electrophoresis. Occasionally, we also look at protein leakage in the urine, and we also try to find out whether this protein in the urine is indeed cancer-associated protein. Now, if we do a combination of these tests, about 95% of multiple myeloma patients will have one or more abnormalities in these tests. Now, after this, like many other blood cancers, the confirmation of diagnosis is by a test called as bone marrow examination, which again can be done largely as an outpatient. It is done under general local anesthesia. We don't need general anesthesia, and it can be done even in patients whose performance status is not very good. So We do bone marrow aspiration, bone marrow biopsy, and we also draw more samples to do more sensitive and prognostic markers called as molecular genetic screening of the cancer, which will help us not only in risk stratifying but also making therapeutic decisions. So this combination of blood test, in some cases urine test, the bone marrow examination will indeed confirm the diagnosis of multiple myeloma, will prognostically risk stratify them, and also help us in further giving treatment.
Thank you so much, Dr. Mallikarjun, for elaborating all the clinical manifestations and the diagnostic part of multiple myeloma. So, moving on to the myths and truths about multiple myeloma, I would like to ask Dr. Ashish, sir, what are these myths that surrounds multiple myeloma?
So, the most common myth we usually come across is the moment we say, first question is asked, is it a blood cancer? We say yes, it is a type of blood cancer. First myth is that blood cancer means it is a death warrant only. So, the answer is it is not a blood cancer of that type which will cause any immediate risk of death if it is managed properly. The management is very easy. I think we are going to discuss more and more about it in the discussion further. But what we need to know is it is more like a chronic disease, just like a diabetes or a blood pressure. The similar way, we just need to make sure how to handle it. We need to recognize it early. So the myth is mainly related to how it comes. Second myth is related to that it involves a high dose chemotherapy that is going to cause major complications or the tolerance will be a problem. Again, that is not true. Most of the treatment is mainly either tablets or it is injections which are just subcutaneous, just like we give insulin the same way. Major part of the treatment is done on OPD basis. So not even an admission required if the person is very stable in the beginning at the diagnosis. Only for complications, for delay in diagnosis or at the initial phase, when the person is say having some problem related to kidney or any other major issues, then only they require admission. Otherwise, it doesn't even require a hospitalization at all. Those are the most common myths that we come across in these scenarios. But yes, the main part is just having a diagnosis as multiple myeloma doesn't mean it's end of the road. The third myth is that the life expectancy is not good. That's not correct. We expect most of the patients with multiple myeloma will live long. They will live long means we are talking about years, and the average survival is touching almost 10 years and beyond right now. So yes, these are the common things that the general population should know.
Thank you so much, Dr. Ashish, for putting light on the myths that are surrounding multiple myeloma. And when usually people get a diagnosis of cancer, they are very scared of it. So this will clear out, and put light on that this is not the scenario now, and early detection can have a better outcome if treated properly. So yes, so moving on to the signs and symptoms. So Dr. Mallikarjun has, discussed about the clinical manifestation. So Dr. Satish, so what are the signs and symptoms of multiple myeloma, if we see?
Yeah, thanks, Dr. Ritika. First of all, there are some power interruption going on, so it may become blank, but my voice will be audible, my Wi-Fi will be active. So again, thank you for the question. So Dr. Mallikarjun has nicely elucidated the common symptoms in short while talking about multiple myeloma. So there are few symptoms which should raise the possibility of myeloma. When patients have the first symptom is unexplained fatigue. See, as Dr. Mallikarjun said, it's a disease of elderly. Usually, people more than 55 to 60 years develop this disease. So, elderly patients with unexplained fatigue. So, when I say fatigue, it can be tiredness, and we have ruled out all other causes. The commonest cause of fatigue we see is anemia. And again, the commonest cause of anemia in India is iron deficiency. Once you rule out common nutritional deficiencies, if it is unexplained anemia, unexplained fatigue, we should evaluate him for multiple myeloma. So first symptom is unexplained fatigue. Second thing is bone pains. So elderly people do have bone pains due to weak bones like osteoporosis. But if they rule out everything again, if the other causes of unexplained bone pains are ruled out, and if the patient complains of pains, especially the pain in the lower back, in the ribs, in the hips, the flat bones, if they have the pain, then we should suspect myeloma and evaluate for that. Third thing is, again, symptoms. The myeloma can affect the kidneys, as Dr. Mallikarjun said. So if they have kidney failure, they can have swelling of the face, fatigue, and increased urination, increased thirst. So those symptoms, unexplained renal failure, again, if they have diabetes, that's different. But if they have renal failure, sudden onset in elderly people, we should evaluate for myeloma. The fourth thing is frequent infections. Patient is falling sick. Once he had a UTI, then he had a pneumonia within 2-3 months. So we should suspect something is going on wrong with the immunity, because myeloma affects the immunity also. They're prone to frequent infections. So unexplained fatigue, unexplained bone pains, unexplained renal failure, unexplained infections is when we suspect myeloma, and do the simple blood test and gradually evaluate for diagnostic test for myeloma.
Thank you so much, Dr. Satish. That was very elaborate and a quick, elaborate plus quick, discussion about the signs and symptoms. So, as Dr. Mallikarjun has said previously, that we do bone marrow biopsy to diagnose multiple myeloma. So, how can we improve this early detection and diagnosis of multiple myeloma?
So Dr. Ritika, your role and the role of other media people is extremely important. So oftentimes, about 10, 20, 30 years before, it wasn't simple to diagnose. In current day and age, diagnosing this condition is not challenging at all. So that is number one. Number two, one thing all of us have to do for our communities and our patients and families is increase the awareness and then talk about what are the suspicious symptoms that one must be wary about and when one must go for evaluation. Dr. Satish, like you rightly mentioned, has very elegantly told all those symptoms. So, number one, this is disease of elderly. So, whenever elderly people have these problems, they must be careful. Number two, sometimes every fatigue, every bone pain, every weakness is not because of cancer. So, we must not, scare people away, right? It can be caused by various other things. But then, if the symptoms are persisting, if the symptoms are not getting better with initial therapy, then that must raise a concern and we must investigate. Now, many times the diagnosis of multiple myeloma is also missed because sometimes when the doctor do evaluation, they do not do all the evaluation together. For example, if you only ask for serum protein electrophores and initial evaluation, an abnormal paraprotein can be detected in only about 70% of the patients. It is quite likely that the patient may be having what is called as light chain myeloma or non-secretory myeloma, which may not be picked up by one test. So comprehensive evaluation of patient when the index of suspicion is high is extremely important. Number two, going to places where people deal with these disorders day in and day out, perhaps would make sure that we don't miss these conditions at all. So the combination of blood test, the urine test, the comprehensive evaluation of paraprotein, and when the clinical suspicion is very high, doing the other further evaluation for skeletal survey, looking for bone lesions, and also doing a bone marrow examination will make sure that we do not miss any case of multiple myeloma. In fact, we might end up diagnosing some of these patients early in the phase of disease, and some of those patients may not even need treatment, what we term as smoldering multiple myeloma. But it is indeed a good thing that we diagnose them early so that we keep them under surveillance. And once the diagnosis is achieved, and once we deem that the patient has active myeloma which needs treatment, the sooner we start treatment, the better is the quality of life, more is the depth of response, better will be the quality of life of patient. So diagnosing multiple myeloma is not a challenge at all, and it can be done very soon. The other thing is many patients and families are very worried about the bone marrow examination. And so the term is a little scary, bone marrow examination. So it is largely done as an outpatient, largely done under local anesthesia, and doesn't need transfusion, doesn't need admission, nothing at all. So it can cause some discomfort, but again, once you give them pain medicine for 2 to 3 days, it shouldn't bother them at all. So diagnosing multiple myeloma is very simple, Dr. Ritika.
Thank you so much, Dr. Mallikarjun. I think you have given a valuable insights to this. Plus, I think people are scared to go to doctors usually, not for cancer, but for their general health as well. If they are going for a general medical checkup, in every 6 months or a year, full health, of a complete body exam. So I think this fear of doctors I must say that there. So awareness is required for everything, and the one main thing that is there is we should reach out to doctors. We should go to doctors at least. Even a healthy person should also go to doctor. I think once a year for a full health examination. So that will, I think, sort some things out, and it will also help in the early detection of some of the diseases which are treatable, and can have a long, in which people can have a long lifespan. And yeah, so moving on to Dr. Ashish. Sir, what are the treatment of early stages of multiple myeloma?
So for the early stages, the treatment is usually done by a sort of targeted therapies. So it includes a combination with newer molecule, which mainly are looking at where is the problem or where exactly the tumor is working. And it is trying to modify its metabolism in such a way that we don't allow these tumor cells to grow more. So there are medicines that work at that level. So there is a medicine called bortezomib or proteasome inhibitors, which usually will be combined with steroid, which will be given as a short pulse doses on a weekly basis. That's a tablet. And the third agent is a new immunomodulator that will modify the immune system in such a way that the immune cells start recognizing these cells much better. They can very well try and kill these cells by itself at that point of time. So your own immune system start taking over gradually. That's the entire logic. So we use a combination with 3 drugs nowadays. And quite likely the newer targeted molecule, which will target mainly the type of antigen that we are looking at on the tumor cells, will also be included as a first line. So the combination of these agents, so the treatment involves a drug called bortezomib, which will be given as subcutaneous. There's a steroid, which will be given as tablet. There is another tablet called lenalidomide or pomalidomide, depending on the center's choice. So any of these can be given as a first line of therapy. In those situations, there are other combinations also which are there. Since it is a very easy treatment and the subcutaneous doses are very simple to take on OPD basis, these patients usually are comfortable taking it on OPD basis. So as I mentioned earlier, unless there are complications, we don't need to admit. So early treatment involves these. We need to give it a cycle. So every week we have to give 1 dose. 4 doses make it 1 cycle. So at least 3 or 4 months of treatment is required before we can assess the patient and see how is the response to therapy. Then we decide how to consolidate this response. So most people will get a response within 3 months. Their bone marrow will come back to normal within 3 months' time. Blood counts will become normal most of the time within 1 month or so. And the abnormal parameters, what we are seeing, will start reversing. In fact, the organ which have got affected in the beginning, quite a large majority of the cases, it comes back to normal. So if the kidney was a primary organ which was affected, then the kidney functions may improve within 3 months if it is supposed to recover within that time. Again, importance for noticing it early and getting a treatment started as early as possible. So the treatment module is simple, easy. It's mainly the person should be starting it as early as possible after diagnosis.
Thank you so much, Dr. Ashish, for simplifying that treatment for early multiple myeloma for us. You discussed about targeted therapy. So, moving on to Dr. Satish, so what are the newer therapies in the management of multiple myeloma, and what is the role of bone marrow transplantation in this?
Right, Dr. Ritika. So as Dr. Ashish elucidated, we give 3 drug regime for newly diagnosed myeloma. So coming to the advances in therapy, we can break it down, maybe advances in diagnosis, advances in treatment of myeloma, and advances in supportive care. Advances in diagnosis, Dr. Mallikarjun has already told, there are simple blood test, comprehensive test, which can diagnose almost 90 to 95% of myelomas, and it has to be done along with a bone marrow test. So these are the advances, and which is done as an outpatient. For kidney biopsy, liver biopsy, we need to admit the patient for a day or 2. But for bone marrow biopsy aspiration, we don't need any admission. It is a simple outpatient procedure. That's about diagnosis. Coming to the treatment, Dr. Ashish has rightly told that there are 3 drugs. Initially, we start with what is called as bortezomib, which is a proteasome inhibitor, lenalidomide, which is an immunomodulatory inhibitor, and it's steroid. So there are newer therapies, like say in proteasome inhibitors, we have something called as carfilzomib, which is a better proteasome inhibitor than bortezomib, which we reserve it for cases of relapse or if the patient doesn't respond to the initial treatment. Similarly, we have a newer immunomodulatory agent called pomalidomide, which is more stronger than lenalidomide. And apart from these drugs, we have newer monoclonal antibodies. Monoclonal antibodies are even more targeted. So monoclonal antibodies means it is recognize the tumor marker on these abnormal plasma cells and attack only these abnormal plasma cells. It will not cause any damage to the normal cells. So we have what is called as daratumumab, which is the latest advance, and it's available in India. So this is one of the innovative molecule in the treatment of myeloma. Finally, we have something what is called as CAR T cells, which is in trial phase in India, but soon it should be available for the general public. This therapy has revolutionized the treatment of relapsed and refractory myeloma. Maybe in the end, when we talk about relapsed refractory myeloma, we can discuss about CAR T cells. So that's about treatment. So we have newer and newer molecules coming, and there are still a lot of molecules in the pipeline. I'm sure after 5 years, if we have the same discussion, Ritika, there are some more molecules which will be used in the treatment to prolong the lifespan of patients with myeloma. Coming to supportive therapy, as initially I told you, they can have anemia. We have safer and safer blood transfusions. If the anemia persists after 2-3 months, we can even give agents like erythropoietin to improve the anemia. If they're having a lot of bone pains and if they have a vertebral collapse, we can do something called as a kyphoplasty or vertebroplasty to decrease the bone pains. And also to strengthen the bones, we have agents called as bisphosphonate and also a newer molecule called denosumab, which help to strengthen the bone. And for patients who present with kidney failure, we start dialysis if it is needed. But as Dr. Ashish said, if we start the treatment early, almost 40 to 50% of the patients, we can reverse the treatment. So these are the advances in supportive care. I hope I answered your question, Dr. Dhiman.
Yes, Dr. Satish, you have very elaborately, discussed about the neurotherapy options plus the supportive therapy as well. And you also discussed about, kidney diseases in the symptoms, that is unexplained urination, and there are some other, symptoms that are linked to kidney. So, in regards to that, I would like to, ask Dr. Ashish, sir, how frequent are kidney diseases in multiple myeloma, and what are the effects of multiple myeloma to kidneys?
So there are two versions of the kidney diseases that we will see. So the common ones that we usually come across is in a multiple myeloma, there is a lot of abnormal antibody production that is going on, or one of the byproduct of these antibodies that will be going on. And these all will create a load on the kidney because they will be coming out through the kidney. The kidney has to excrete that waste product. Kidney is the organ which usually handles it. So when it is trying to do that, it will get damaged because most of these are toxic. So as the more and more these abnormal protein get deposited, it may create problems there. So 30% of the people may come with kidney failure, the frank kidney failure. Some of these may even go on the verge of dialysis requirement or may need dialysis for a short time. So in 30% of the cases, it's the nephrology department which will first notice that there is a possibility of a multiple myeloma, and they will draw the attention. The second common department is going to be, or the most common department is usually the orthopedics or a spinal surgery or a neurosurgery, where the bone pain usually comes and the bone lesions are there. Second type of kidney problem is when the myeloma type lesions are usually restricted to the kidney only, and that is the only organ, something called monoclonal gammopathy of renal significance, where also we need to treat, and we need to treat like a multiple myeloma, and they are also something that respond very well to the treatment with the multiple myeloma base. So yes, kidney problems are common. The incidence is common. Again, reversing very fast in majority of the cases to normal within 3 months.
Right. Thank you so much, Dr. Ashish. So, as you said, that 30% of the population with multiple myeloma may have kidney diseases in this regards. I would like to ask Dr. Mallikarjun, sir, what is the criteria for autologous bone marrow transplant for patients with multiple myeloma? As Dr. Satish has, um, briefly touched upon bone marrow transplantation. We want to know the criteria for autologous bone marrow transplant in this regards.
Thank you, Dr. Ritika. Again, so bone marrow transplantation, no scary word. I think we need to do something about these words, Ritika. Yeah. So when we talk about transplants, we largely divide transplantation into two subtypes, right? We call that autologous bone marrow transplantation, allogenic bone marrow transplantation, number one. Now, the term itself has various other things. We call it hematopoietic stem cell transplantation. We call it blood and bone marrow transplantation. So conventionally, when people were started doing bone marrow transplantation, they would collect the stem cells from the bone marrow. We don't do that very often now. In majority of the transplantations that we do for the blood cancers, we don't actually collect the stem cells from the bone marrow. So that is number one. I want you and your viewers to understand that largely we now collect stem cells by what is called as mobilization of the stem cells into the peripheral blood, put the patients or the voluntary donors on a machine called as apheresis machine. It is the same machine which is used to collect platelets, right? So number one, it need not necessarily be collection of the stem cells from the bone marrow. Number two, coming to the transplantation in multiple myeloma. So when we talk about a bone marrow transplantation in multiple myeloma, we're essentially talking about what is called as autologous bone marrow transplantation, meaning we will collect the stem cells from the patient himself, right? So like Dr. Satish and Dr. Ashish has told you, the moment we diagnose the patients of multiple myeloma, we initially give them treatment, and that is called as induction therapy. The idea is to reduce the burden of the disease as much as we can. Largely, we say 3 log reduction. That's a mathematical model, right? And once we do the induction therapy, post induction, we assess the response based on what yardsticks. We have the baseline parameters, right? The monoclonal paraprotein, the kappa lambda light chain ratio, the protein in the urine, the plasma cell percentage in the bone marrow. So at the end of the induction, we're going to assess all of that and then categorize the responses into complete response, partial response, very good partial response, stable disease, progressive disease. So we do that. Now, in patients who have had good response, either complete remission or very good partial remission, we'll have to decide about consolidation strategies. And why is it important? Despite a very recent and a quite remarkable advance in the treatment of multiple myeloma treatment is still not curative in intent. Yeah. So we have to put the patients into long-term remission so that they have long first remission, so that their quality of life is better, so that the patient and families can spend more time away from doctors, away from hospitals, which is extremely important, right? So in order to do that, we do what is called as autologous bone marrow transplantation. So once the disease is under good control, we collect the stem cells from the patient and then we admit them in clean rooms called as bone marrow transplantation rooms and give them very high dose of conditioning chemotherapy, which in most cases in myeloma is a medicine called as melphalan. So we give very high dose melphalan. The idea is to destroy as many cancer cells as possible. Now, mind you, even when a pathologist says there are no plasma cells seen in the bone marrow, even when the paraprotein says no abnormal paraprotein detected, does not mean we have cured the cancer. It is just that it is below the level of detection. So even in such patients, there is still significant disease burden. So the idea of giving a very high dose melphalan is to destroy as many bad cells as possible. And when we do that, conventional chemotherapy agents don't pick and choose and kill only cancer cells, right? They do myeloablation. So to rescue patient from the ill effect of the high dose conditioning therapy, we reinfuse their own stem cells. And again, reinfusion of stem cells is simple. It's just like blood transfusion or giving any other intravenous, fluid, for example. So conditioning therapy, reinfusing the stem cells, and then accelerating the recovery from the ability effect, right? And how do we do that? So before we do the bone marrow transplantation, we do the disease-related assessment, we do the patient comorbid-related assessment, and we also send them to doctors like cardiology team, pulmonology team, dental medicine to make sure they're fit to undergo to this transplant. So induction therapy, pre-transplant workup, conditioning therapy, stem cell infusion, and post-transplant care, which is about 20 to 30 days of admission in the BMT unit, making sure the stem cells repopulate and make the new bone marrow, making sure we follow the patient closely, and even after discharge for the immune reconstitution, we follow them for some more time. And once that is done, we put them on post-transplant maintenance. So this is still, as of today, the standard of care. And every patient who's less than 70, or even fit patients who are even elderly, who have a good disease control, must undergo autologous bone marrow transplantation.
Thank you so much, Dr. Mallikarjun, for elaborating the whole process and the criteria for us. As Dr. Ashish mentioned that, after Hemat, the second busiest specialty is nephro, and after that, it is ortho. So, Dr. Satish, how do you manage bone diseases in myeloma patients?
Yeah. So as illustrated earlier by all the speakers, one of the commonest presentation of multiple myeloma is bone pains. So these bone pains are mainly in the flat bones, mainly in the back, the spine. So they present with back pain, the rib pains, or the hip pain. This pain is more on movement. So if they're lying down still, there is no pain. But if they move on the bed or make any changes in position, they do get severe bone pains. So once we diagnose them to have bone pains, there are various ways of managing them. The first and foremost treatment is the primary treatment of myeloma with the three drug regimen, as I said, because they destroy the plasma cells and make sure further bone destruction doesn't happen. The mechanism of bone destruction in myeloma is an imbalance between new bone formation and bone resorption. So these cancer cells secrete some toxins which resorb the bone, and new bone formation does not take place. So we give agents called as bisphosphonates or denosumab. Any agent can be given which will strengthen the new bone formation and makes this bone stronger and decreases the bone pains. Suppose if someone has a vertebral collapse and is causing severe bone pain, then we can do a simple surgical procedure. Sometimes it's done as a daycare procedure called as a kyphoplasty by a spine specialist, where they inject bone cement into the bone to increase the height of the bone, which will drastically reduce the pain. And of course, apart from the primary treatment, bisphosphonates, we have to give adequate analgesics for these patients who are suffering from bone pains. We avoid the routine painkillers like combiflam, brufen, diclofenac, because that they can damage the kidney. But there are other agents which are safe and kidney friendly painkillers which we can give to alleviate the pain. So these are the various modalities to manage the bone pain in myeloma.
Thank you so much, Dr. Satish, for explaining us how we can overcome bone issues or bone diseases in myeloma patients. So, Dr. Mallikarjun, sir, as it is a multifactorial disease, after there are some complications in kidney and bone complications. So, what are some of the challenges associated with treating multiple myeloma, and how can you think we can overcome those?
Yeah, so it's a very good question indeed. And sometimes things are very simple in theory, but the real world comes with its own challenges. Number one is spreading awareness, and I think all of us are doing that today, right? Number one, making sure the patients who need help know that there is help available. Number two is the issues of diagnosis, right? The sooner we diagnose, like any other cancer, the better equipped we are to help these patients and families. So early diagnosis is extremely important. Number two, initiating treatments. We all must know cancer therapy does not typically one size does not fit all. So when we start treatment, we must look into not only the cancer diagnosis, not only the molecular genetic signature of the cancer, but also patient as a whole, right? The guidelines are simple, but we also have to look at various other things. So we must individualize treatment for every patient, looking at his age, his comorbid illnesses, what are his aspirations, what are the family's aspirations, how much healthcare is accessible to them, how good they can follow up with the healthcare team, which is extremely important. So early diagnosis, individualizing care is very important. Now, one of the things which is an elephant in the room that we don't often talk is the percentage of patients who have healthcare or financial help for both diagnosing and treating such disorders is extremely less in our country. And unfortunately, that becomes a big challenge for both caregivers and patients and families. So one, they have to accept and live with a diagnosis of cancer, no matter how well you say it, and then how much courage you give, at the end of the day, it has effects of causing great emotional distress and turmoil. And second, they have to cope up with being able to spend from their pocket. And most of these illnesses are long drawn and have significant financial burden on the patients and families. So all of us will have to perhaps do more awareness, not only with communities but also with governments and other team members, so that these patients can get some financial help. So disease related awareness, trying to help patients and families in terms of mobilizing funds. The next thing is the psychological trauma, the caregivers burnout. So we still have to have care groups. We'll have to try and make sure there are care groups available for them to talk to, and then to feel the emotional support. There are also onco-psychological counselors, which all of our hospitals have, and they are also going to be of great help. So no matter how hard we try, I think we will always fall short in helping these patients and families, but we must continue to try and help them in every possible way.
Thank you so much, Dr. Mallikarjun. I think you have rightly mentioned that there is not just one stakeholder for not just this disease, for any disease for that matter. There are multiple stakeholders that are there, being it emotional health of patient or financial health of the patient or physical health of the patient. I think the policymakers, patient support groups play a major role here, apart from the doctors that are there. So yes, you have rightly mentioned that. And moving on, patients are also scared of the side effects of the treatment. So, Dr. Ashish, sir, what are the potential long-term side effects of multiple myeloma treatments and how they can be managed?
So that's a common question that is asked to me in the clinic all the time. And the answer is simple. I think I would rather say it is to be seen in the context of first is, do we see more problems with the disease or with the treatment in the beginning? The moment that is clear that if we don't treat it, we are going to see more and more problems, then the issue of side effects will come to the backstage. Then side effects are something that we'll have to live with. Same thing is there with the diabetes. Same thing is there with any other chronic lifestyle illnesses. Fortunately for myeloma, the advances have been such that most of these drugs have less side effects. Most of these are easily tolerable. The side effects are also something that initially what we expect most of the people may have are intestinal issues. Some may have constipations, some may have loose motions. Most of these are manageable. Quite a large number of people actually get side effect not by the newer medicines that we get. It is more with the side effects of the steroid, which is used so commonly in different immunological conditions also. So steroid is the one which usually causes more fatigue, more tiredness, and that's also something that usually they get adjusted after a couple of months. So initial phase, the side effects seem more mainly because the disease is also active, and the disease problems and the medicine problems also combine together. Later on, as I said, treatment is OPD based, so most of these patients, they don't get any major issues as such. As we continue using it longer, then the medicines, every medicine can have problems. So this medicine also, there can be issue of the nerve damage. So we do need to keep monitoring. The doses of the medicines are adjusted according to the symptoms of the person, whether they are seeing any signs of nerve damage or not, whether there are symptoms related to that, because myeloma itself can cause one of those symptoms. So that's why we need to be very careful in using. Some of the medicines will drop the blood counts, so hemoglobin may drop, platelets may drop. So we do need to monitor. So they require frequent blood testing before we can give the medicines further. Long-term basis, when we use these drugs, then some of these may cause a bit of more diarrhea even when they are a tablet. So side effects are mainly in context of what drug combinations we are using. When we are talking about bone marrow transplant, then bone marrow transplant, of course, has more side effect because it's a traditional chemotherapy-based consolidation. So yes, there are real risks related to that. But most of the discuss is to the level of minimum. So that's why this is a standard therapy worldwide, whether it is here or abroad. The treatment of multiple myeloma with bone marrow transplant is being done despite its being a traditional chemotherapy. Subsequently, What we need to do is just using some tablets, maintaining with those tablets, and once in 3 months is a usual follow-up. Most of those drugs are easily tolerable. Initial phase, there can be sometimes a skin rash with those tablets also, that also fades away later. So skin rashes is something very common. But longer term use, the drug is very well tolerated. So side effects are something which are highly individualized. I think it is something that we as a person don't read the side effect. You come back and tell us what is the problem. We will tell you whether it is related to side effect or not, and we will adjust the dose accordingly. That is the best way to manage any of these problems. So I don't think so that side effect should be the one that should deter a person or getting afraid of of the disease as such. It's mainly the disease they should try and target and control it as much as possible, because subsequently, once they control the disease, it's relatively very comfortable life, and after that they don't even need to visit the doctor as frequently. They visit almost as frequently as any other chronic disease. I hope
Thank
I
you so much. Yes, yes, you have very much elaborated all the things that are there. I would like to add one point here as it is a disease of elderly patients. Usually, patients have other comorbidities at this point of age, which also contribute. Their medication also contribute to such side effects, and it develops a fear for those as well. So I think that is one point that is there also. Yeah, so we have discussed about the signs and symptoms, the challenges, the treatment, the diagnostic part of it. Now, Dr. Satish, how can we best manage relapsed or refractory multiple myeloma?
Right, Dr. Ritika. So, as Dr. Mallikarjun told in the beginning, myeloma, unfortunately, is not a curable cancer. We can control it, just like diabetes, we can control it now for several years, but we cannot cure it. So, what I mean by that is, it will eventually come back, and it depends when it comes back, but it will come back. So, that is called, when the myeloma comes back, we call it as relapse disease. Refractory means it is not responding to the initial treatment. So, there are two different things. Relapse disease, when the disease comes back, how do we decide treatment? It depends on a lot of factors. First thing is, now what is the age of the patient? Second thing is, how long it has been when we have given the initial treatment, and now what is the duration of the response? Has it come back very fast within 1 year, 2 years, or has it come back after 4 or 5 years? Then the other thing is, as you rightly said, comorbids. Is a patient having diabetes, blood pressure, any heart issues? Then the next thing is whether the patient has undergone transplant in the initial setting or not. Yes, we do autologous transplant for most of the patients, but some patients in India, for whatever reasons, they might have preferred not to take chemotherapy. Sorry, not to undergo the transplant, and have just continue the chemotherapy. So whether they have undergone transplant or not. And finally, is this patient having renal failure at present, because some drugs cannot be given when they have a high creatinine? And last but not the least is finances. How are the finances? So we take into consideration all these factors to decide what treatment we should give in relapse disease. For example, if a patient is less than 65 years, has not undergone transplant initially, we definitely try and plan transplant in the second time when they relapse, of course, after getting the disease under control. So what drugs do we give when they relapse? Again, it depends on the initial treatment. If the disease has relapsed very early, we don't give those three drugs. We change the DEXA, the steroid will be the same, but the other two drugs we try to change to a newer immunomodulator, newer this proteasome inhibitor, as I mentioned, carfilzomib, pomalidomide, or newer drugs. And sometimes, if the patient can afford, we can even add a monoclonal antibody called as daratumumab, which increases the efficacy. They all act in synergy and increases the chance of response, and even response very fast also. So this is how we decide. And the other thing is, yeah, so fair enough. So whenever these patients relapse, we do take into consideration all these factors and decide what is the best treatment for the patient. And we need to remember that even if the patient relapses, they should not get worried that it is the end of the road. We do have all these newer medicines which will prolong the lifespan of the patient significantly. Now we have second relapse, third relapse. We have treatment for every relapse. And as I mentioned earlier, a lot of newer drugs, a lot of newer advances are happening, and a lot of newer drugs are in the pipeline.
Thank you so much, Dr. Satish, for explaining that to our viewers. And so now I have three questions from the audience as well, if you would like to answer that. So So, Dr. Ashish, sir, one question is from the audience that they are asking if it is just the disease of elderly, or you have seen such cases of multiple myeloma in, say, 25 to 40 years of age as well. You are on mute, sir.
My apologies. Average age of multiple myeloma in our country is around 60 years, so 55 to 60 years. So most of these diseases, any of the disease, if we take into account, usually it starts 10 years ahead in our country compared to Western world. Having said that, the range usually we see is between 50 to 70 or 80 years accordingly. In young people, it is less common. It is much less common. And the youngest person that we have seen was 23-year-old. So yes, there can be disease like myeloma in a younger person. The biology of disease is different. Treatment doesn't change. Treatment is usually the same. It depends on what is the type of the disease in terms of what is the genetic risk factors. What genetic means, when I say genetic risk factor, then it is related to more often the mutations that the cells have acquired or developed, not their genetics. Means it's not the genetics of the person, it's a abnormal cell or the cancer cell which has mutated. So in those, based on that, we do risk stratification, try and find out is it a high risk or a low risk. So if you look at the number of risk profile, those in the younger age will have a tendency to have more aggressive disease compared to those in the older age group. So that's how your usual pattern is. Every person is having an individual profile. So it's more to do with that. Relative percentage will always be different. So yes, occasionally we will see it in 20s, we will see it in 30s. So you can see it in a younger population. There is no denial of that. But yes, that is not the common age. Most of the people will be having it beyond 45, 48 only. So that's a common. So between 50 to 60 is a common age that we see. Yes, of course, elderly is something that will be common everywhere.
Thank you so much, Dr. Ashish, for answering that. Moving on, we have another question. So, Dr. Mallikarjun, one of the viewer is asking if it is hereditary. So, if their parents have it, do they have it, or how is it?
Yeah. No, everybody wants to know. Do I need to screen? Is it contagious? Can we share food? Yeah. So yes, these are the myths. I think both Dr. Satish and Dr. Ashish alluded to some of these. So number one, no. So largely, majority of the myeloma patients, this is not an inherited condition. So if the parent has it, or if somebody has had it, we don't necessarily screen the children. So it is not transmitted from the parents to children as such. It is largely because of acquired clonal mutations. That is why it is a disease of elderly. Yeah. So we would not consider this as genetically inherited cancer at all, at least not at this point in time.
Usually most of the cancers are seen as breast cancer are seen as if their parents have it, they have a higher risk
So,
associated
so,
with it. But
so it's a good point. So the reason why I'm saying at this point is, so about 30 years before, we did not consider cancer as a genetic disease at all, right? Now, as the
right.
cancer research is being done, more and more we are realizing everything in some way is related to the genes, right? Including obesity, for example. For a long time, we would say, if you eat more, exercise less, that is why you are fat. Now we know there are fat genes and lean genes, right? Similarly,
Mhm.
BRCA genes in breast cancer. So I'm sure as the cancer research, throws more and more light, we'll find more and more answers. But at this point, this is not one of those Mendelian inherited genetic condition, cancer, multiple myeloma, I meant.
Right. Thank you so much, Dr. Mallikarjun. So we have one more question. Dr. Satish, I would like to ask you that is this associated with any lifestyle changes? Is there any lifestyle changes that we can do to have this not have this
That's right.
disease in the patients?
You mean, Ritika, to prevent the disease?
Yes, for the prevention of the disease. Are there any
Yeah,
lifestyle changes that
unfortunately.
they can do to prevent? Yeah.
So unfortunately, it is not a preventable malignancy. As Dr. Mallikarjun said, it is due to mutations in the stem cells in the bone marrow, which we cannot prevent. Of course, having a healthy lifestyle helps in a lot of ways to prevent cardiovascular disorders, to prevent some cancers, but not for myeloma. Especially, there's no significant or particular lifestyle change which can avoid or prevent myeloma. See, I'm sure the viewer would have asked, because we say don't smoke, it prevents 20 types of cancers. Don't drink, it prevents liver cancer. So there are many of those for some cancers, but unfortunately for multiple myeloma, there is no prevention, or the only thing, as you rightly said in the beginning, we need to have a high index of suspicion. Patients more than 45 years should undergo health checks regularly, because if there are any clues, we can evaluate further and diagnose it early, pick it up early before any complications develop, because they'll tolerate the treatment better. But there is no single or multiple prevention strategies for myeloma.
Right. Thank you so much, Dr. Satish. So, with this, I would like to conclude this session. So, if I can have a one-liner message from you to the audience, so it will be, a very wonderful session with you. It had been a very wonderful and insightful session with all the esteemed speakers here. So, if I can get one-liner message from all of you, starting with Dr. Mallikarjun, sir.
Thank you, Dr. Ritika. Thank you all. I would say all cancers are not same. Early diagnosis and early treatment is the key. And I wish you all very well. Thank you.
Thank you so much, Dr. Mallikarjun. Dr. Ashish.
My message is always don't get scared of the disease. Know the disease and know the treatment is available. As long as we have solution, anything is possible in terms of achievement. So I think better not to get scared of the disease. It's time to actually go forward and then take it head on.
Thank you so much, Dr. Ashish. Dr. Satish.
I would echo what Dr. Mallikarjun and Dr. Ashish has said. Don't get scared. Talk to your healthcare provider, talk to your hematologist, and make sure all the myths associated with the disease are cleared. Because as soon as a diagnosis of cancer is made, there are a lot of myths. Is it hereditary? Is it contagious? Can it be treated? Is it the end of the road? So please speak to the doctor and clear all your myths. And myeloma is a treatable disease. It can be controlled for several years. And there are a lot of drugs in the pipeline. So don't be scared.
Thank you so much, Dr. Satish. I would also want to add one more thing, that don't Google your symptoms. Go to a doctor. So it is always best to have someone who has been an expert in this area, who have studied a lot, to reach here and, treating patient with their experience and everything. If you have any symptoms, you should reach out to the doctor. You should go to the nearest hospital and you should talk to the doctor first. So thank you so much for taking time for this insightful and wonderful discussion today. Thank you so much, Dr. Satish, Dr. Mallikarjun, Dr. Ashish.
Thank you all. Good night. Bye-bye. Bye-bye.
Good night.
Good night.